This poster will examine the current state of research on the effectiveness of DBT for prisoner rehabilitation and suggest future directions of DBT research and treatment for this population. Compared to the general population, incarcerated individuals are approximately 5 times more likely to be diagnosed with a mental illness. Approximately 1/3 of prisoners with mental health issues have received treatment since admission to a correctional facility. Research has shifted towards the implementation of more effective prisoner rehabilitation, and this includes examination of evidence-based treatments to be implemented in correctional facilities. Much of the previous research has emphasized cognitive behavioral therapy, which has been demonstrated to reduce the risk of recidivism to up to 55%, but more recent research has focused on third-wave approaches to increase effectiveness of rehabilitation. DBT is a cognitive behavioral treatment which was originally created to treat borderline personality disorder in adults to address self-harm and other destructive behaviors. The goal for DBT is to teach clients skills to assist them in their emotional regulation, interpersonal relationships, and distress tolerance while addressing the client's sense of reality. Although treatment with DBT has been shown to be effective for behavioral and emotional problems, research with DBT in correctional facilities has been limited. In treating forensic populations, the R&R, Risk, Need, Responsivity model has been shown to be the most empirically supported method of rehabilitation. This model dictates that treatment is tailored to the client's risk level, most relevant risk factors, and responsiveness to treatment. The skills taught in DBT appear to align with the R&R model in targeting the most significant risk factors for criminal behavior. These include antisocial attitudes, antisocial personality types, and pro-criminal associates, crime-related thinking and behaviors, and regulation skills which address emotional responsivity and victim empathy are also important topics. DBT has also been adapted to address other risk factors such as substance use and marital and family factors. Some modification of DBT for use in correctional facilities has been required as the typical participant is male, has a co-occurring diagnosis of antisocial personality disorder, and has a history of destructive behaviors which have caused harm to themselves and to others. DBT-CM is a condensed version of DBT which focuses on coping skills. It includes shorter sessions held twice a week for 16 weeks. DBT-CM-HIP recognizes that participants are typically male and includes activities with more typical male focus. It also includes an additional skills module addressing criminal behaviors. The RUSH model included simplification of language and acronyms found in DBT. It also takes into account the realities of incarceration for these participants. Studies suggest that programs in correctional facilities which were more faithful to the standard DBT protocol and delivered in an R&R framework were more effective in reducing recidivism and risk. However, there were problems with most of the studies in that they did not utilize control groups, and lack of random assignment makes it difficult to determine whether DBT is more effective on recidivism than other forms of treatment. Future research in this area is needed to improve the quality of studies, the size of research samples, and the fidelity in which the protocol is administered. The limited research done on DBT in correctional facilities has demonstrated some effectiveness in rehabilitating inmates and addressing antisocial personality traits. Greater implementation of DBT could assist in this rehabilitation.